Yes, a very good evening, Madhuri, Rajkumari. A very good evening. So we will wait for 5 more minutes for the students to join. Then we will start the session. Yes. So, my dear students, I welcome you all to the Friday Power Up NORCET series, which is coming exclusively under your Plan C Plus English edition, right? So, every week on every Friday we are coming up with a live session with high yield hot topics which are most probably asked in your examination, right? If you have not watched the previous videos, do watch the previous videos and share your inputs. And today again we are going to talk about one of the most important topic. It is the most important topic, that is your burns. So let's get into the session. So here in this video, each and every line you're going to study is going to be the MCQs. At the end, we are going to discuss some of the important MCQs, which is clinical based MCQs. So it is very important to watch the video till the end, be with me till the end, so that whatever MCQ is going to come in the topic of burns, you're going to answer it so easily, right? So let's get into the session. So first, as you all know, today we're going to discuss in detail about burns and its MCQs, which is clinical based. So the first and foremost thing you have to remember is, when you are referring the patient, what is the referral criteria for a burns patient, right? When you are referring the patient to the burns unit. So when the burns is involving the face, hands, feet, genitalia, perineum and major joints, when it is involving with major organs and major structures which needs a critical evaluation and management, there where we are shifting the patient immediately to the burns unit. When the patient is having a chemical burn, when the patient is having an electrical burn, and any form of inhalation injury, because inhalation injury are directly going to attack the airway and cause asphyxia further. So it is very important to admit inhalation injury patients also to the burns unit. Next, the patient with partial thickness burns which is greater than 10% of your total body surface area. As you all know, we will discuss about what are the components of your total body surface area, what are the scales and what are the parameters we are using to calculate your total body surface area. Then when the patient is having a 3rd degree full thickness burns in any age group, then you are immediately referring the patient to the burns unit. So here select all questions can come, so it is very important to note these things. So when the burns is involving the critical areas such as your face, hands, feet, genitalia, perineum and major joints, when the patient is a chemical burn and electrical burn and inhalation injuries, then you are admitting directly to the burns unit. And any form of partial thickness burns which is greater than 10% in your TBSA, then you are taking up the burns admission. And 3rd degree burns, irrespective of the age, either it is a adult patient or a child patient or a pediatric patient, you are definitely admitting them to the burns unit, right? So next, this is again asked in your examinations. Okay, so what is mean by zones of burns? As you see here, this zones of burns is otherwise known as your Jackson's theory of burns. Okay, zones of burns is termed as your Jackson's theory of burns. So why we are studying about these burns? Like, why we are studying about this theory? When we generally talk about burns, we always talk about this zone of coagulation, zone of stasis and zone of hyperemia. But why do we talk about this? On the assessment, when you find out whether in these 3 criteria you find out the patient is coming under any criteria, the structure is coming under any criteria, you're determining what kind of management, what will be the prognosis of the patient. To analyze that only, we are studying about this zones of burns, that is termed as your Jackson's theory. So to identify the patient's prognosis and what kind of management as a healthcare professional I have to deliver to the burns patient, that has to be determined only with the help of your zones of burns, that is otherwise known as your Jackson's theory. First is your zone of coagulation. So when we talk about zone of coagulation specifically, it is irreversible necrosis. If there is a word irreversible, you always know you cannot retain or you cannot salvage that particular area from the necrosis aspect, right? So when there is a zone of coagulation, what will be the priority management? So here the priority management will be what? Already the area has been necrosed, it is irreversible necrosis. Now tell me what kind of management is applicable for patient who is exhibiting zone of coagulation state more. Now tell me, if the patient is having a zone of coagulation area or more, then what will be your priority actions or priority management which we are doing for that burns patient? So obviously you will be going for your Escharotomy, so when they are going for such phases or such zones, the ultimate aim of the management will be to perform an Escharotomy or whatever to manage that particular area that we will be doing. So next is your zone of stasis. As the name implies, here it is salvageable. Whenever you see a word salvageable, which means we can regain the action or regain the utility of that particular tissue with proper management, that is termed as salvageable. So whenever you see a word salvageable, which means I can able to reverse the action of that particular tissue. So here, what will be your priority management? When the patient is going for stasis, what will be your management? So obviously we have learned it is salvageable. Here, proper fluid resuscitation will be your ultimate management. Just listen, if it is reversible, ultimately you know, because of increased permeability of your blood vessel, there will be leak of fluid into your interstitial space in the burns. So obviously there will be severe vasoconstriction and your blood heme concentration will be increased so much. So here the ultimate initial aim is to revascular those events, which means I have to rush the fluid so that my blood vessels get adequate amount of resuscitation. Then this permeability is getting alterated, then the shift of fluids will be happening in sequence in the proper manner. So here in zone of stasis, when the tissue is salvageable, I have to maintain a good perfusion to that particular area so that the blood circulation towards that particular area is improved and the healing process will be better, right? So here the management is about what? Fluid resuscitation and maintaining the proper perfusion. Next we have zone of hyperemia. In zone of hyperemia, these are vasodilated area where you have to leave that area without any without any management. These areas will be healed spontaneously. So it is very, very important to note about your zone of coagulation, zone of stasis, and zone of hyperemia. Whenever you think about zone of coagulation, think it is an irreversible necrosis. You cannot salvage it. Whenever you think about zone of stasis, which means it is salvageable. Yes for stasis and yes for salvageable, which means I can able to regain the action of that particular tissue when I'm going to do a proper management. Next is your zone of hyperemia, which means a good circulation is there, but a vasodilation is there. These areas need just a supportive care in order to promote proper wound healing. Then the most important additional point you have to remember here is, see here, in zone of stasis, it is very, very important to perform all the barrier techniques and aseptic precautions while performing any form of dressing or any procedure to the burns patient, right? So here where you have to prevent the infection and also you prevent the further necrosis of the tissue. So next we have the classification of burns. So here you have in first degree, epidermis is involved, red and tender appearance will be there, and there will be blanching and pain will be present. And healing process will take 3 to 5 days and no scar tissue is formed. This is again a key point for you. Next is second degree, that too we have superficial. In superficial, both your papillary and dermis layer is involved, and blisters and red color appearance will be seen, and S obviously blanching will be there, pain will be there. And what about the healing? Healing without scar again. Then this is very crucial part where deep, second degree deep burns. Here your reticular layers including your dermis, everything is involved, and the appearance is pale, less tender, and here blanching will be partial and pain may be variable. If there is a deep injury, burns injury, and there is a damage to your nerve conductions and nerve cells, at that case what will happen? There will be no pain. That will be seen in case of your third and fourth degree burns, right? So here you can see the hypertrophic scar, and here the management will be your split thickness skin grafting. Next, in your third degree burns, the entire dermis, starting from your epidermis, dermis, and the subcutaneous tissue is involved in the burns. And here the appearance will be charred and painless. Because why it is painless? Because there was a damage to the subcutaneous tissue and the preceding muscle, which is going to cause severe nerve damage, thereby there was no pain impulses. So blanching will be not present and pain is also not present. So this also requires your split thickness skin grafting. So the fourth degree, which involves your muscle and your bone. Here where black eschar formations are seen in your fourth degree burns, and there will be no pain and no blanching. So extensive debridement is required in this case, right? This is not that much important, but the upcoming things are very, very important, right? So initial management of burns. So what are all the initial management of burns? First is your airway management. In your airway management, how will you identify the patient is going for airway, like the airway is affected, the patient is having some inhalation burns, how will you able to identify? With the help of these criteria, you can come to the conclusion that the patient's airway is affected in this burns. So first is burnt or singed nasal hair. What is meant by your burnt or singed nasal hair? Which means there will be burnt hairs which will be present, and singed means also it is meaning the same. Burnt or singed having the same meaning, which means you will be having some blackish tarry appearance where your hair follicles are burnt, and it can be visualized, right? So the patient will be having burnt or singed nasal hairs, which is the most specific sign. Whenever they are asking which is the most specific sign, then you will be answering it is burnt or singed hairs. Singed hairs. So this is the primary and most specific form of finding you can see in the patients involving airway burns. Next is hoarseness of your voice, soot or carbon in the sputum. The patient will be exhibiting black color sputum. The patient will be exhibiting black color sputum. And closed room fires. In case where there is a closed room fire, there will be excessive inhalation of the smog which is appearing inside the room, right? So that is again a factor which is preceding to your airway burns. Next is burns in face, head and neck, and altered sensorium, because the patient will go for hyperventilation initially, then for hypoventilation, right? So what is the prophylactical management you will do is intubation is the first indication to prevent the airway prolapse. Even primarily the burns patient with airway burns, initially they will be exhibiting the normal SpO2 levels, but it is in precursor stage where the patient will be going for asphyxia in future and lung collapse in future. So obviously when you suspect the patient is having an airway burns, then definitely you have to plan for your intubation, which means the physician will be planning that the primary responsibility of a nurse will be arranging the equipments for the intubation only, right? And early airway edema can be fatal if it is missed, because once lung collapse is happening, then the airway edema will be there where there will be complete compression of your airways, which in turn going to cause the situation more worsened. So it is very, very important to secure with an endotracheal tube for any form of airway burns. Next is your stages of airway burns. So first is, your patient will be having acute pulmonary insufficiency because of excessive smog inhalation and pulmonary edema. The patient is going to have pulmonary insufficiency, where you can see the decreased SpO2, and the patient will be feeling breathlessness due to carbon monoxide buildup in the alveoli. Then followed by, the patient will be projecting your acute respiratory distress symptoms, and bilateral infiltrations and hypoxia will be seen in your chest X-ray. So last stage, they will be going for bronchopneumonia. So first remember, acute pulmonary insufficiency, ARDS. At last stage, the patient is going for bronchopneumonia. In earlier stage, it is because of your Staphylococcus aureus in 1 to 3 days. Later, after 3 days, it is because of your gram-negative bacteria. Right? So next is your breathing. The patient will be having hypoxia, carbon monoxide poisoning, and eschar on the chest. When they are going for deep burns, in that case, there will be eschar formation, which is going to reduce the chest expansion, right, which in turn again going to cause hypoventilation. So you have to treat the CO poisoning like how you will be treating the carbon monoxide poisoning, by administering 100% O2 or hyperbaric oxygens, right. So next, for circulation, if the patient is presented with inflammation, when you consider it localized, when it is less than 10% of your total body surface area, you are considering it is localized, and if it is greater than 10%, you are considering it as generalized. So here, what is actually happening in circulatory failure is, capillary leak is there because of excessive disruption because of the burns. There will be a capillary leak, which means your permeability of your blood vessel will be increased, which in turn going to release the intravascular components. The intravascular fluids will be leaking outside into your interstitium, right. So when this fluid is leaking into the interstitium, blood vessel will be having adequate flow of blood, right. So when there is an interruption in the permeability because of the burns injury, what will happen? This fluid will be shifting to the interstitial space. So what happened? This fluid entry into the interstitial space is causing edema in the burns patient, which is termed as your third spacing edema. Then it will lead to hypovolemia as well, because all the fluids in the blood vessels are leaking towards your interstitial space. Obviously, the patient will be going for hypovolemia, and the circulatory failure will be there in turn, right? So what is the management? So you have to monitor the burn shock in the first 24 to 48 hours, and fluid resuscitation is one of the most important management. Ramya, very good. Yes. Next is fluid resuscitation. Parkland formula we are using, and a very, 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 very important point you have to note here is, the Parkland formula is 4 ml into your body weight into your total body surface area. How many of you know the Parkland formula has been updated? If someone knows, please comment me in the chat box, like, what is the updated Parkland formula for your fluid resuscitation in burns. Parkland formula is only used for fluid resuscitation. For colloid resuscitation, we have different formula. Just remember, for fluid resuscitation, we are using Parkland formula. Now comment me, what is the update in the Parkland formula? I'm waiting for your answers. Yes, please give a big round of applause to Priyanka Patra. It is 2 ml of your ringer lactates plus, into your body weight, into your total body surface area. And the recent updates are telling there are different formula for adult, for children, and for electrical burns and all. So we will be learning that in detail, right? So this is the final thing, and this is the old formula. Now we are going to learn about new formula in future, right? So what is even though the updates has been came, that is your 2 ml into body weight into your total body surface area is the updated formula. Even for the same fluid resuscitation formula, the administration method is same. What is the administration method? As you all know, you will be dividing the fluid into 2 halves, and in the first half of the fluid will be delivered will be administered in the first 8 hours, and the next half of the fluid will be administered in the next 16 hours, right? For example, it is 500 ml of fluid. For example, I'm telling it is 500 ml of fluid. When you divide by 2, it is 250 ml, right? So what you will do, 250 ml you will be administering in the first 8 hours. Then another 250 ml we will be infusing for the next 16 hours. So this is again a very important point. Like, they can specifically ask you, very good Deebesh, also very good, you are also correct. So they can specifically ask you, like, in first 8 hours how much of fluid you will be infusing. They will be giving all the total body surface area, weight of the patient, and they are going to give the percentage of burns, everything, and they will ask you to calculate the fluid resuscitation. You will calculate it very carefully. Obviously, you know the formula. That is very simple. Again, you have to know the updated formula as well. And if at all they are going to ask you in first 8 hours how much amount of fluid you're going to administer, in next 16 hours how much amount of fluid you're going to administer. So in that aspect also you should be very clear, because day by day your NORCET examination is becoming very tricky. So you also learn all the trick before going for the examination, right? So always the preferred solution is your ringer lactate. Whenever there is an MCQ, what is the preferred solution in the management of your burns? That is your ringer lactate. And tell me, what is the preferred route of administration? It is a common question, but it is very important. The preferred route or highly recommended route of administration is IV. Okay, that is your intravenous route. So start within first hour of the injury in order to regain the capillary perfusion. In order to regain the capillary perfusion, right? So next, disability assessment you will be doing. You have to monitor for GCS and any form of traumatic brain injury, and you have to assess for loss of consciousness. In case of inhaled injury and carbon monoxide poisoning, you suspect the patient will go for loss of consciousness because of hypoxia. So exposure, again you have to assess the extent and cause of the burns with the help of your rule of 9, that is your Vilas calculation. Very good Priya, very good Arpita, very good Deebesh. Yes, for example, if they are directly, like, if in the upcoming examinations, they're going to definitely ask, you have to calculate with the help of updated formula only, because the old formula is expired and the updates has been came. So definitely you have to use the updated formula only. But what to do is, just apply both the formulas to be on the safer side if they are preparing the key without any updates. If they are extracting from the previous pool, if the key is without any updates, that time also we will be caught. So what you have to see the options. You have to do both the calculation. For 2 ml also you will do, for 4 ml also you will do. Then at the end you can come to the conclusion, like which of the following answer is listed. Based upon it you can answer effectively. That will be the primary thing. But most of the cases it will be updated only. So you use 2 ml formula only, right? So exposure, what you have to do, you have to assess the extent of burn and the depth of burn, right? So here also you have to remember, you should not, for example, the person who has burnt injury with all his clothes infused, in that case you should not drag the clothes and all, because it is going to further worsen the injury. So that also coming under your exposure part. So maintain the normothermia. Why? The burns patient will be going for hypothermia. The burns patient will be going for hypothermia. The risk of hypothermia is so much because of heat loss. Why the heat loss is happening? Why hypothermia is happening? All the skin are evaded because of burns. In that case, definitely the normal barrier mechanism, the normal thermoregulation will not be maintained. So the patient will go for hypothermia. So it is very, very important to maintain the patient in normothermia, right? Again, it is very important to note the patient physiologically will go for hypothermia when they are having more percentage of burns. So here we have the rule of 9 and all the calculations of your total body surface area. So calculation of TBSA, that is your TBSA calculation. So TBSA calculation is done in 3 forms. First is your Lund and Broder formula. As you all know, obviously, whenever you think about London Broader formula, you always think it is for pediatrics. Yes, obviously, it is very much critical in the pediatric, but it is also used for adults also. So it is standardized by age. As per the age, you can able to standardize and you can calculate the TBSA, and it has a gold standard accuracy. Again, it is an MCQ point. So which particular TBSA calculation tool is having a gold standard accuracy? Best accuracy is there in your Lund and Browder only when comparing to your rule of 9. In rule of 9, there is a lot of chances like you can over calculate or you can hyper calculate, right? So here, but it is very time consuming because 99999 calculation is very much easy, but here you have ABC bifurcation and then the calculations, so that's why it is quite tough. So when we talk about rule of 9, it is body is divided into 9 segments and quick and simple method where you can immediately start the resuscitation. That's why this method is used in greater extent when comparing to your Lund and Browder. So risk of overestimation of your total body surface area is possible, and this is one of the limitation factor of your rule of 9 that you have to remember. Next is your Palmer technique, which is not followed in many areas, but additionally in exams they can ask you to trick you. So that case you have to remember. So 1%, like if you have, like we have specific calculation for this Palmer, like how much you have to calculate if the whole hand is fixed or only the half of the palm is fixed, so that we have calculation. And useful for small and scattered burns. Like when this burns is very minimal, in that case we are using this Palmer calculation. And high interuse variability is there, like it is not used in many areas and it is not that much standardized. So first is your Bayes rule of 9. See, listen, rule of 9 was given by the author, Bayes rule of 9. So remember, head, it is always 4.9. So this is anterior. This is anterior and this is posterior. Always you have to remember both anterior and posterior before going for your examination. Please don't confuse yourself. So head as a whole, it is 4.5%. And coming back to the trunk is again bifurcated into 2. That is 9% for your upper trunk and 9% for your lower trunk. And both the upper extremities you can see, it is 4.5% and 4.5%. Anterior complete upper extremity is 4.5%. Okay, then the left side and right side completely, the anterior aspect is 4.5%, right? Again, for genitalia, in the anterior aspect it is 1%, the whole lower extremity, anterior aspect alone is 9% and 9%. So when we talk about the posterior aspects, 4.5% for the head, again the trunk, it is same rule, again for your again for your posterior upper extremities it is same rule, and for your lower extremities it is 9. So here it is very critical to note, head as a whole, it is what? Head as a whole, it is 4.5 plus 4.5, it is 9. Again, when we talk about trunk, it is, in the anterior it is 18, the posterior it is 18, plus 18 plus 18 is equal to your 36. Then genitalia is only 1, you have remembered. And talking about the upper extremities, it is 4.5 anterior plus 4.5 posterior. So upper extremities is 9 each as a whole. When we talk about the lower extremities, one lower extremities, anterior plus posterior, it will be 9 plus 9, that is 18. One lower extremity is 18%. Okay? Yes. So next we are going to talk about Lund and Browder's chart. Here they are not going to ask about the calculations in your Lund and Browder, but you have to see the chart once before going for the examination. So in Lund and Browder chart, you have to remember they have given A, B and C. So A stands for your head, A stands for your head, B stands for your thigh, B stands for your thigh, and C stands for your leg. Right. So this is very important to note in your Lund and Browder chart, because which of the following areas is marked as A, B and C? So you have to remember A is marked as, head is marked as A, and B, thigh is marked, and C, leg is marked. That you have to remember. Like, they don't have calculation. This A, B and C will be calculated based upon the age. So here you can see age they have listed 1, 2, 5, 10, 15 and for adult, right? Same way they have given for head, thigh and legs. So here there are the readings for your head, thigh and legs as per the age group of the patient. But other areas, if you see, it is always marked in numbers only. Head, again they marked as A, neck is 1. See, they have bifurcated the upper extremities into 3 parts. If you see, 2 and here 1.5, and the hands it is 1.5. Like that they are calculating. For example, how much will be the total? 2 plus 1.5 plus 1.5, it is going to be 5, and 5 in each side. So trunk as a whole, anterior is 13, here also is 13, genitalia is 1. Again your lower extremities is calculated as thigh and your leg. Based upon the age it is calculated, and your palmar area is again is 1.75 and 1.75 each. But this calculation is not that much needed for you people, but you have to know the basic thing, like what is Lunn-Bowder chart, what is the classical differentiation. You have to remember A, B, C area, that is your head, thigh and leg, or calculated the percentage of TB, the percentage of burns in your head, thigh and your leg, or calculated in respective to the age. So next we have the Palmer method. So rule of palms, right? So in pediatric population and adult population is this varying. For example, if you take a pediatric population, 1 complete palm, right? It is calculated as 1%. For example, I have a burns in this area and 1 particular palm is completely placed in the pediatric population, then it will be 1%. When only the palm, okay, rejecting your digits, and only your palm, then you are calculating as 0.5 in case of pediatric population. On the other hand, when we talk about adult, 1 whole palm, 1 whole hand is calculated as 0.8. Please remember this. For adult, it is not 1%. For adult, it is 0.8%. Again, rejecting the digits, it's 0.5%. It is similar for both adult and pediatric population, but 1 whole palm's calculation is differing from the pediatric and adult population. For pediatric population it is 1%, for adult population it is 0.8%. So here where the most important table we are going to talk about, a very, very, very important table. So without reading this table, without revising this table, never ever go for your examination. Never go for your examination without seeing these tables, right? So first is the updated formula, the updated Parkland formula you're going to learn here. So if the burns is a flame or scald burns and the population is adult or older children, where the age group is greater than 14 years, greater than or equal to 14 years, so what is the formula? The formula, please remember, that is 2 ml into your body surface. Please cut. Yes. That is your 2 ml into your body weight in kgs into your total body surface area which is burnt, right? Your total body surface area is calculated in respective to the rule of 9. And 2 ml is indicating your ringer lactate solution, and body weight is the body weight of the patient. So here, again, the most important exam perspective point you have to remember is, if I'm going to follow this formula for my fluid resuscitation, what is the expected urine output I expect from the patient? That is again very, very important, right? So if I am starting the resuscitation with 2 ml into body weight and I am calculating the fluid, in that case I expect the target urine output should be greater than or equal to 0.5 ml per kg per hour. It should be greater than or equal to 0.5 ml kg per hour of urine output after I am successfully starting this resuscitation. This is a very, very important exam point you have to remember. Next is children. For children less than or equal to 14 years, in that case you're going to use 3 ml into your body weight into your total body surface area which is burnt. Again, the same calculation. So you can see 3 ml we are using here, and 3 ml is indicating your ringer lactate solution. 3 ml is indicating your ringer lactate solution, body weight respective to the child, and your total body surface area of burnt. Right? So next, please remember, for adult it is 2 ml and for pediatric population it is 3 ml. And what is the expected urine output for a pediatric population? It is 30 to 50 ml per hour. It is 30 to 50 ml per hour. Please don't confuse yourself. It is ml per kg per hour, but here I am given as a whole 30 to 50 ml per hour. Right? Yes. Again, coming back to the infant and young children whose weight is less than or equal to 30 kg, then again I am using the same formula, that is 3 ml into your body weight into your total body surface area which is burnt, and additionally I am starting with sugar containing solution at the maintenance rate for perfusion. Right? Yes. So here in infant population, what is the expected infant and young children whose weight is less than 30 kg, what is my expected urine output? It is greater than or equal to 1 ml per kg per hour. It is greater than or equal to 1 ml per kg per hour. So next, in case of electrical burns for all age groups, the same old formula we are using. Again, here the target urine output is 1 to 1.5 ml per kg per hour. So you have to continue the fluid until myoglobinuria clears, because in case, because of excessive muscle breakdown, the patient will be having myoglobinuria, right? So in that case, in order until the clearance of myoglobinuria is attained, we are going to do the fluid resuscitation effectively, right? So next we have a colloid resuscitation in burns. So again, I have said you total body surface area and your Parkland formula, everything is utilized in case of your what? In case of your fluid resuscitation. But after fluid resuscitation, after 12 hours, we will start colloid resuscitation. So for colloid resuscitation, what formula we are using? For colloid resuscitation, we are using Muir and your Barclay formula. For colloid resuscitation, you are using Muir and Barclay formula. So what is the indication? When the burns is greater than 20%, at that case you are going to start with colloid resuscitation after 12 hours in respective to your total body surface area. So type of fluid, as you all know, colloids are different type of fluids, right? The examples of human albumin, plasma, and your dextrine. What is the timing of administration? It is very important to note. You have to start after the first 12 hours post burns, because colloids, when you give colloids, if there is a proper perfusion only, the colloids will actively work. If again, for example, if you tell, already my capillaries is so much shrinked, and again in that shrinked capillary, if I am going to administer colloids and all, this is again going to leak to the interstitial spaces, and it is going to cause further edema. It is going to cause what? Further edema. So what I have to do? I have to do a proper fluid resuscitation and maintain my capillary permeability with a good volume. Then if I am going to give colloid, there will be proper absorption. If in the constricted blood capillaries, if I am going to give colloid, again this will go to shift to the interstitial space. So that's why you have to start the colloid therapy after 12 hours. You have to start the colloid therapy after 12 hours. So obviously, post burns, the patient will be having declined capillaries because of the permeability, right? So once I will start the fluid resuscitation, the capillary will be regained and to the normal structure. Then I will administer the colloid and it will be effective. When I am going to administer in this stage, again, the interstitial leak will be there because of the colloid administration, right? So here you have to remember the timing of colloid administration. You have to start in the first, like you have to start after the first 12 hours post-burn, right? In your initial 12 hours, you have to do only crystalloid therapy only because of this following mechanism. So what is the rationale behind this? Early colloids risk of edema due to increased capillary permeability in the first 12 hours. Yes? Yes, colloids formula, please remember the formula, that is very important, but they are not going to ask you this much depth, but it is very important. If you keep on learning about resuscitation formula and they come to one conclusion that everyone knows resuscitation formula, then now I should start with different approach, right? When they think in that aspect, what they will do, let me put a question on colloid resuscitation so that they will struggle. So if they are going to put colloid resuscitation also, because of this lecture, you people are going to answer that also, right? For colloid resuscitation, please remember you are using your Muir and Barclay formula. The formula is the colloid volume you have to infuse is 0.5 ml into your percentage of total body surface area into your body weight. The same formula you are using for colloid, you are adding 0.5 ml. You have to remember 0.5 ml into your total body surface area into your body weight, right? The administration, you are going to divide the fluid into 6. You are going to divide the fluid into 6, which means, for example, the fluid you have to administer is 1200. So if you are going to divide 1200 into 6, it is 200. Okay, it is 200. So first 12 hours, 3 infusions at 4 hours interval. 3 infusions at 4 hours interval, which means you're going to administer 600 ml of fluid in the first 4 hours, like in the 4 hours interval each, in 3 infusions. For example, 200 ml in the first 4 hour, next 200 ml after the second 4th hour, and next 4th hour you're going to administer the another 200 ml. Next, in second 12 hours, 2 infusions you're going to administer in 6 hours interval. So now you have administered 200 ml, 200 ml and 200 ml in 4 hours interval. So now what are you going to do? You are going to administer 200 ml in 1 6 hour and another 200 ml in the next 6 hours, right? So at last, in third 12 hour, 1 infusion. The rest 200 ml you will be administering as a last infusion in the last 12 hour, right? So in total, how many hours of administration journey here? It is 32 hours. Your colloid resuscitation will be happening after 12 hours of your fluid resuscitation. Then you will be going with the colloid resuscitation, where the total duration of your colloid resuscitation will be 32 hours. 32 hours, where you are splitting 32 hours into 12 hours and you are starting the infusion. For first 12 hours, what are you doing? For first 12 hours, 3 infusion in 4 hours interval you are doing. The total amount of fluid which you calculate, that you have to divide by 6. You have to divide into 6 equal halves and you're going to split and you're going to administer. That is what is given here. But this is not that much important, but remember about the formula, that is very important. Colloid formula is 0.5 ml into your total body surface area into your body weight. That you have to definitely remember. And the name of the formula you have to remember, that is your Muir and Barclay formula, right? So monitoring the expected and targeted urine output is very similar to your fluid resuscitation, that is 0.5 to 1 ml per kg per hour. So what is the advantage of this colloid resuscitation? It reduces the risk of excessive tissue edema, right? And it maintains the plasma oncotic pressure. When you're going to administer colloids, it is going to, sorry, it is 36 hours. Yes, it is 36 hours. Thank you, there is a calculation error. It is 36 hours. Ramya, very good. So advantages, it reduces the risk of excessive tissue edema and it helps in maintaining the plasma oncotic pressure. The important nursing consideration after colloid resuscitation is you have to strictly monitor the IO charting and monitor for allergic reaction and adjust the fluid based on the response. If at all you are not receiving, like if at all in conditions where I'm not getting an adequate urine output even after the proper fluid resuscitation and colloid resuscitation, then consult with the physician. You have to immediately inform to the physician and you have to alter the fluid resuscitation rates, right? Yes. So next, the dressing materials of burns. Again, a very important component you have to remember. For first degree burns, you're not going to administer any form of dressing. Just you're going to expose it to the air and it will be healed properly. In second degree, so here in second degree superficial burns especially, you're using Vaseline gauze and collagen dressings if it is not an infected wound, right? So next, in second deep burns, in second degree deep burns, you're using collagen and hydrocolloid dressing. Example is your deodorant, right? Just remember, first degree, you're not applying anything, no dressing is done, just you're exposing and allowing the burns to heal by itself. In second degree, you're using Vaseline gauze and collagen. If the wound is not infected, you're using collagen dressing. In second degree deep burns, you are definitely using collagen along with your hydrocolloid dressing. Example is your deodorant. The next important thing you have to note is the additional important agents we are using in the burns management is your silver sulfur diazine. So silver sulfur diazine 1% you are using, that is the most common component which you are used in the burns dressing, and it needs frequent change. That will be your disadvantage of your silver sulfur diazine. Okay, 1% component concentration you are using, and it is very most commonly used and needs frequent changing of the dressing. So silver nitrate is another important component, and you people will be remembering about silver nitrate only to the greater extent. Yes, but silver nitrate has an important disadvantage, that is it strains the wound so black. Once you administer, if you see the images of silver nitrate dressings, it strains the area of burns into very tarry black, right? So that is one disadvantage, and it has very poor eschar penetration. This drug is not going to penetrate inside the eschar and promote the wound healing. So this drug is not now recommended more commonly, right? So next is your mefenide acetate. Your mefenide acetate penetrates the eschar painful. Like see, this mefenide acetate is having an important antimicrobial components and everything, and it penetrates the eschar and promotes wound healing. But it has an additional disadvantages. What are the disadvantages? It is very painful after the administration, and this causes metabolic acidosis. This particular dressing material causes metabolic acidosis. So that is very important to note. So we talked about silver sulfur diazine, silver nitrates and its effects. Silver nitrate causes black appearance. It strains the wound into black color. That is very important to note. And eschar penetration is very important in wound healing. Silver nitrate does not do eschar penetration, but your mefenide acetate does very good eschar penetration and promotes wound healing, but it has a high yield disadvantage, that is it is very painful while administering, and it causes metabolic acidosis as well. So you have an important dressing material, that is your selenium nitrate. Recent advances and recent studies, everything is telling that selenium nitrate is one of the best modality for burns dressing, which promotes wound healing to the greater extent, including for pseudomonas also it is creating a good effect in the management and prognosis. So that is considered as a best agent, and it is rarely available, but it is a very best agent. So it is very important, like these materials, okay, these dressing materials can override your pseudomonas bacterial infection also, right? They promote wound healing by creating a barrier in the wound. So that is the importance of this burns dressing. So here we have the picture of your mefenide acetate. So next is nutrition in burns. Again, the most important topic you have to remember, because these are all possibly asked in your examination. So as you all know, burns is a hypermetabolic state where there will be increased amount of calorie consumption will be there. There will be increased calorie consumption. Calorie consumption will be so much high in burns patients, right? So what happened when there is an over calorie consumption? Obviously, you have to externally give a good amount of calorie support to the patient in order to promote a good prognosis, right? So here you have to note that it is an hypermetabolic response where burns patient will be having increased basal energy expenditure. So for severe burns patient, what is the recommended calorie allowance you have to do? The recommended calorie allowance you have to do for the burns patient in severe cases is you have to approach 40 kilocals per kg per day. You're going to administer the patient 40 kilocals per kg per day, which is 2 times more than the normal consumption, because burns is an hypermetabolic state. It is an hypermetabolic state where excessive energy is consumed. So that's why we are giving this more calorie administration in order to override this hypermetabolism. So what is the recommended calorie allowance? That only you have to remember, it is 40 kilocals per kg per day. So nitrogen loss. So now again, nitrogen loss is an important event, physiological event which is happening in burns patient. So if the patient is going for nitrogen loss, so when this nitrogen loss is peaking, when this particular nitrogen loss is peaking more, so it peaks at 5 to 10 days post burns. At 5 to 10 days post burns, this nitrogen loss will be more higher. So to compensate that only, we are going to give protein for the patient. So to compensate the nitrogen loss, we are going to give a good amount of protein in the burns patient. So you have to start at least 20% of the total calorie should be proteins in the calorie which you are calculating. So 20% of the nutrients you are going to give to the patient will be proteins, right? Remember about this 40 kilocals per kg per day, and this 20% of the total calorie you give should be protein in order to overcome the nitrogen loss in 5 to 10 days post burns. So next we have the protein requirement formula for burns. The protein requirement formula for burns is termed as your Davis formula. So here we have the formula, that is 3 gram per kg plus your 1 gram into your total body surface area which is burned in case of children. Why in case of children it is higher? Because they have higher baseline of growth and development. That's why it is 3 gram divided by your kg, 3 gram per your kg plus 1 gram into your total body surface area. For adult population, same formula, but 1 gram per kg plus 3 gram into your total body surface area which is calculated. So for all these calculation, for protein calculation, for fluid resuscitation, for everything, your TBSA plays a very important role. That's why it is very important for all the nurses to learn about the calculation of your TBSA with rule of 9. Rule of 9 should be always in your fingertips. Rule of 9 should be always in your fingertips. So next, the final management at the necrosis state is Escharotomy we are doing. So what is meant by Escharotomy? You are cutting the eschars. Okay, you are cutting the eschars. For example, this is your thigh. This is your thigh. This is your thigh, and the pressurization is greater than 30 mm of Hg. 30 mm of Hg. At that case, what are you doing? So to relieve that pressure, I am doing a cut. To relieve that pressure, we are performing a cut of that eschar into the deep fascia, So what area, like what particular area we are using, that is also very important to note. You are cutting the eschar and you are into deep fascia you are going, and you are relieving the tension and pressure of that eschar area. Right, that is termed as your Escharotomy. So this is done in case of your compartment syndrome and circumferential burns, as we listed here. It is done in case of your compartment syndrome and circumferential deep burns where the pressure is exceeding more than 30 mm of Hg. Right? So critical pressure, when it is going for greater than 30 mm of Hg, we are going to perform Escharotomy. So it is cutting the eschar plus your deep fascia to relieve the pressure and to normalize the healing. So bleeding control, we are using your diathermy. So in surgery, you might have learned about diathermy, monopolar and bipolar diathermy. So these diathermy or cut and coagulation devices where it gives current, electrical energy to cut and coagulate the major blood vessels, right? So here when the patient is having profuse bleeding, for bleeding control, we are going to use this diathermy to coagulate that particular area and to prevent the bleeding. So post-operative care, nursing important care which you have to give for these patients is hemostatic dressing plus limb elevation. Hemostatic dressing plus limb elevation. So what is meant by hemostatic dressing? Eschar means that, like, it is a dark layer which is formed. Like in Brenner and Siddharth, if you see in Burns chapter, you can see the image of Eschar formation, and even there is an additional image there where they have performed Escharotomy. Right? Refer and Brenner and Siddharth, Ramya, dear. Okay? So hemostatic dressing plus limb elevation, if you talk about hemostatic dressing, you know what is hemostatic. Obviously, in order to arrest the bleeding, I am performing those hemostatic dressing. So here in Burns patient also, post Escharotomy, we will be applying this hemostatic dressing. What this hemostatic dressings, what are the additional components these hemostasis dressing is having is, they will arrest the bleeding, okay, they will arrest the bleeding, as well as what they are doing, as well as they accelerate the normal clotting mechanism. These hemostatic dressing materials, they accelerate, okay, they accelerate the normal clotting mechanism. They accelerate the normal clotting mechanism. Right? So what is the goal of Escharotomy? That is restore the circulation and relieve the pain because of excessive pressure, and to prevent the necrosis. So causes of death in burns, again MCQ part. What are all the causes of death? What is the immediate cause? Whenever there is an MCQ, what is the immediate cause of death in case of burns patient? Within minutes to hours, your answer will be asphyxia. What is meant by asphyxia? Because of circulatory failure, because of ventilation and perfusion failure, there is poor supply of O2 to the whole body. That is termed as asphyxia, which will lead to organ failure when it is treated. When it is not treated properly, it will go to organ failure. What is asphyxia? Your ventilation, perfusion, and circulation failure. Right? Where the patient will go for severe hypoxia, severe oxygen deprivation to all the organs. See, compartment syndrome is like because of circumferential burns. When the patient, for example, if it is like one part of in the upper aspect, if I'm getting a burns, that is different. Like I can do the dressing and everything, and I can manage it, right? For example, the whole area is affected. In that case, what will happen? Okay, in that case, what will happen? There will be complete this interstitial fluid leak, and everything will be complete, and this complete part circumferentially it will be accumulated with a lot of fluids. That is termed as your compartment syndrome, and complete fluid leak from your capillary membranes to your interstitium will be there. So that complete encircled wound is termed as your compartment syndrome, right? So to relieve that cases also, this compartment syndrome, because of excessive fluid accumulation, there will be increased pressure. So what happened? The pressure is keep on increasing and increasing and increasing. At last, there will be severe tear and wound damage will be there. So that's why we are artificially doing this escharotomy to create an opening into the deep fascia, so that we are relieving manually that pressure with aseptic technique, right? So next we have the important causes of death. The first and foremost, this MCQ point you have to remember is, within 1 hour or immediate cause of death for burns patient is asphyxia, very common in your airway injuries, right? Later, neurogenic shock. Now tell me, what are all the classical findings of neurogenic shock? Answer me in the comment box, what are the classical findings of neurogenic shock? So this happens because of airway obstruction from inhalation injury and severe form of smoke. Answer me the classical features of neurogenic shock. Next, in early phase, like 1 to 3 days, what will be the cause of death? It will be hypovolemic shock because of massive fluid loss. In late phase, greater than 3 days, so what will be the cause? Septic shock. And the overall most common cause for death in burns patient is because of improper barrier maintenance. This in turn going to cause septic shock, right? So septic shock is the most common and overall cause for death in burns patient. Please keep that in your mind. And next thing you have to remember is, what is the immediate cause of death in burns patient? Then your answer will be asphyxia. More than asphyxia, neurogenic shock. When asphyxia is not in the option, then you can go for neurogenic shock, right? So early cases, it is because of hypovolemic shock, like 1 to 3 days. Greater than 3 days, it is because of septic shock. And most common overall reason for death in burns patient is septic shock, that you have to remember. So next we will go to the MCQ part, the most interesting part, where you're going to test yourself, like what is your level of learning about burns. So many people have completed your, very good. Please give a big round of applause to Mona Lisa. She has talked about the special features of your neurogenic shock, that is hypotension and bradycardia, or seen classically in your neurogenic shock, right? Yes, 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 very good, Divesh. Yes, now let's start about with our MCQs. So a 28 years old male is brought to the emergency department following a house fire. He has facial burns, singed nasal hair, hoarseness of voice, and black carbonaceous sputum. Remember children, whenever they are giving a term, okay, coal sputum or carbonaceous sputum, everything is telling about that black sputum which is happening because of inhalation burns injury, right? So the patient is having black carbonaceous sputum. His oxygen saturation is 94% in room air. What is the most appropriate immediate nursing intervention? Now you people have to answer me what is the correct answer. Yes, I'm waiting for your answers. Very good. Very good. Most people have answered correctly. Priyanka, Mona Lisa, Priya, Arpita, Rami, Ramya, Sidesh, Bandi, and Muva. So like as I said in the discussion in the first, like when I was talking about the first slide, I said you, if the patient is having facial burns, singed nasal hairway, hoarseness of voice, and black and carbonaceous sputum, and it is indicating the patient is having airway injury. Okay. So what will happen initially, even though the patient is having the oxygen saturation of 94% in the room air, later the patient will be going for lung collapse, pulmonary edema, then lung collapse, then complete asphyxia. The patient will be going. So before, in order to prevent it, the first and foremost, before airway is constricting, we have to open the airway. So that's why it is very important management you have to note is prepare for endotracheal intubation. The nursing important immediate intervention is preparing for what? Endotracheal intubation. Initially the patient's saturation may be good, but later what will happen? But later the patient will go for airway collapse, lung collapse. So before it happens, we have to secure the airway. We have to promote the breathing, right? Administer humidified oxygen via face mask? No, because the patient has already exhibiting all the important symptoms and the patient will be proceed for airway edema. So it's very important to proceed with endotracheal intubation when comparing to your administration of the oxygen, right? So next is perform chest physiotherapy, such a relevant option. Obtain the atrial blood gas sample. That is also very important, but it is not the primary responsibility. Getting ready with intubation materials is very, very important, and we are getting ready for endotracheal intubation. So next, a 35 years old male weighs 70 kg with flame burns involving 50% of total body surface area is admitted. According to Parkland formula, he received off of the calculated fluid within first 8 hours. Now, 10 hours after the burns, the nurse observes his urine output to be 15 ml per hour. So what is the best nursing intervention? So now tell me, what is the answer? A quite tricky but an easy question. Yes, yes, very good. Priyanka, very good. You are on the track. Yes, people who are answering C, now tell me what is the rationale behind the answer C? Many people are answering A. Just put the rationale. Devesh is also answering A. Put the answer. Put the rationale, sorry, put the rationale. So listen children, we have started the fluid resuscitation as per the Parkland formula, right? We have started the fluid resuscitation as per the Parkland formula. And you see, the patient has received half of the fluid. Okay, he has received half of the burns resuscitation fluid. And we are observing the urine output. It is 15 ml. So what is the target urine output? What is the target urine output? We have studied about target urine output for adult patient after resuscitation. Now tell me, the target urine output after burns resuscitation is what? For adult patient, what is the targeted urine output? We have studied it clearly. Now put me in the comment box, what is the targeted urine output for the patient who is in the fluid resuscitation? Very good, Priya. Your answer is correct. Output is less. That's why we are going to increase the IV fluid volume. But I want, yes. Priyanka Patra, please give her a big round of applause. Like if you were with me. Yes. Oh, wise. Very good, very good, very good, very good, very good, very good, Priya. Very good. So, the targeted urine output we are expecting from the patient after fluid resuscitation is greater than or equal to 0.5 ml per kg per hour. Per kg per hour. So, here you can see there is 15 ml. So, here the patient's weight is 70. So, obviously the patient should get 0.5 ml per kg. So, obviously I am multiplying 70 into 0.5. So what is the answer? It is 35 ml. The patient should get the urine output of 35 ml per hour, but he has given the urine output of only 15 ml per hour. So you just have to adjust. We people have to adjust what? We have to adjust the fluid resuscitation, because the expected fluid output is not there. So definitely we have to adjust or increase the rate. So here we have to increase the IV fluid infusion rate. That will be your correct answer, because the expected fluid urine output is not there, which means if the expected urine output is not there, which means the patient is not going for adequate fluid resuscitation, right? So in that case, you have to alter or you have to increase the fluid resuscitation so that the salvageable tissues can get a good amount of perfusion, right? Without wasting the goodness, right? I hope everyone has understood it, or I will repeat it for once again. Yes? So listen, what was the question telling? A 35 years old male patient whose weight is 70 kg with the flame burns involving 50% of total body surface area of burns. So according to the Parkland formula, he received half of the calculated fluid within first 8 hours. Now, 10 hours after the burns, the nurse observes the urine output. So initial 8 hours, the patient has received the fluid resuscitation, whatever he wants. after immediately starting the fluid resuscitation, we will be targeting the urine output and monitoring the urine output. If the urine output is adequate, we are feeling that the fluid resuscitation is very good and the patient is going to be good. So, but if you see the fluid, after fluid resuscitation also, the urine output is very much less. The targeted urine output is greater than or equal to 0.5 ml per kg per hour in patient, adult patient. But here, you are getting, so you are calculating. Again, the targeted urine output you know very well. That is greater than or equal to 0.5%. So you are calculating for 70 kg patient, what is the targeted urine output after the resuscitation? It is 35 ml per hour. But here the patient is projecting 15 ml per hour, which means inadequate fluid resuscitation is maintained. So that's why you have to increase the fluid infusion rate, right? So continue with the current fluid rate. No, the urine output is very much less, and administer IV furosemide. If you are going to administer IV furosemide, what is going to happen? You are administering fluid in order to maintain the vascular permeability in proper manner, right? You have to maintain the vascular fluid volume. So that's why you are administering fluid. If you are going to administer IV furosemide, again the vascular volume is going to reduce, right? Again the third spacing will be more only. So that's why you have to increase the IV fluid resuscitation rate. So insert Foley catheter for output monitoring. Obviously, for a 50% burns patient, definitely we have proceeded with urinary catheterization. So this intervention is irrelevant. So I hope you people have understood this concept. So let's go to the next question. A 42 years old male present with a deep partial thickness flame burns involving the entire right arm, anterior trunk, anterior surface of his right leg. Using Welles's rule of 9, what is the estimated total body surface area which is burnt? Now come on, answer in the chat box. A 42 years old male patient present with deep partial thickness flame. The burns is see this, how much fluid we should increase. See, that will be based upon the physician's order, right? We cannot decide how much fluid we can assess, and as per the physician order, we will be proceeding with the fluid resuscitation. Okay, dear Shruti? Yes. So many people are answering C. Many people are started to answer C. Yes. Some people are answering B. Sure. Let's check. So let me draw an good diagram on your anterior and posterior part of your. See, please ignore my diagram. So this is anterior and this is posterior. Consider this is your upper extremity and this is your lower extremity. Now tell with me, anterior 4.5% for your head, back side 4.5%, upper trunk 9, lower trunk 9, here also upper trunk 9, lower trunk 9. In the anterior aspect you have genitalia, which you are going to give 1. Upper extremity anterior aspect 4.5 in each arms. Lower extremity again in the posterior aspect it is 4.5 and 4.5. For your lower extremity as a whole, anterior it is 9, again anterior other extremity 9. Posterior again the whole extremity 9 and 9. Right? Yes, 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 yes. Very good, very good, very good. So now let's calculate entire right arm. I'll use different color. Yes. Entire right arm. So entire right arm is this 4.5 plus 4.5 is equal to 9. Okay? Anterior and posterior. So entire word is there. So they are telling whole, the whole upper extremity. Anterior trunk. So anterior trunk, as you all know, it is 9 plus 9. It is 18. Right? 9 plus 9, it is 18. Then anterior surface of his right leg. So anterior surface of his right leg is 9 again. So using the Wales rule of 9, it is what? The answer is what? 9 plus 9 plus 9 plus 9. That is 18 plus your 18 is 6, 3, sorry, 1, that is 36. See, actually I am very poor in maths. Please ignore it. Okay. So that's why I choose nursing. Okay, obviously it is 36 percentage. I hope it is very clear. Like, these questions are quite confusing because whether they are talking about anterior aspect or posterior aspect, you will be confused in that terms, right? So that case, you just put a rough diagram immediately because it is 1 mark. It is 1 mark. Why it is 1 mark? So that why I should put an image and all. You can ask me a question because one of my cousin is very good. Most of the people who has come to nursing because of weak in maths. I was at to pursue engineering. My parents were compelling me to do engineering only. But since I was very weak in maths, I felt like I cannot again learn that theories and theorems where I struggled in 12th standard. So let me go to nursing. I was targeting for medicine, but I could not get a medical seat because I was so lethargy during my 12th standard. So you people also should not be like that. If you're going to be very cautious and studying so properly in this phase of your life, definitely you can achieve your dreams as well. But after studying nursing, I never stopped myself. I was so empowered, I was so energetic, I was a gold medalist. So that's how it is going. So whatever you do, love it and do it, definitely it will work. Right? Yes, Muva, Priya, same story. Shweta, everyone, same story. Yes, I'm also the same story. So coming back to the question, so these kind of questions are quite tricky and it needs quite important critical analysis to do. All about you, this is memory based. You are going to remember this rule of 9 and you're going to produce it in the answer. So what you have to do is, okay, so what you have to do is, you have to put a rough diagram and you have to calculate and put the answer. Because what will happen, right? You can think it is just a matter of 1 mark, but there are many students who went inside your aims with 1 mark and many students who came outside because of the lack of 1 mark. There is lot of chances with minimal percentile people will go inside with 1 mark, 2 mark in the sink, they come outside. So 1 or 2 marks is a decider in your competitive examination. So definitely you should concentrate and work on it. Right? So I hope this is clear. So they were talking about the entire right arm. So we calculated entire right arm, anterior trunk, only the anterior trunk we have calculated. Then the anterior surface of the right leg we have calculated. The answer is 36 percentage. Am I right? Yes. Let's go to the next question. A 36 years old male has sustained a deep partial thickness flame burns involving the entire back, posterior left arm, anterior left leg and perineum. So based on the Veras rule of 9, what is the total percentage of burns? Yes, now answer me. Now answer me with the correct answer. Many students have started answering. Good, good, good. Good, good, good. Again, for my idle children, let me again draw the diagram so that you will also remember. This looks like some ghost diagram, na? Please ignore. anterior and this is posterior. Okay, I hope you will never forget this diagram. So again 4.5, 4.5 anterior and posterior, upper arm 4.5, 4.5, 4.5, 4.5, upper trunk 9, lower trunk 9, perineum 1, upper trunk 9, lower trunk 9, extremity, lower extremity 9 and 9 and 9. Right? Now let's calculate with different color. Yes. Entire back, so entire posterior part 9, posterior left arm, posterior left arm. So posterior left arm is 4.5 and anterior left leg is 9. Then your perineum is 1, so plus 1. So that is 9 plus 9, 18 plus 1 is your 19 plus your 4.5, that is 32.5. That is your 32.5. Yes, sorry, I'm calculating the wrong way. Yes, I was just checking you people's alertness. Okay, yes, coming back. Entire back 9 plus 9 is it is 18. Posterior left arm is 4.5 plus your anterior left arm, your anterior left leg is plus 9 plus your perineum, that is 1. So what is the final answer? Yes, what is the final answer? It is 32.5. It is 32.5 is the correct answer. So please make sure you don't make any wrong answers while doing this calculation. Whenever we are talking about the entire back, you should definitely remember it is not 9, it is 18. That's why I made it, right? Yes, the correct answer is B. So let's go to the next question. A 60 years old child, weight is 20 gram, present with second degree scald burn involving 25% of the total body surface area. According to the modified fluid resuscitation protocol for pediatric burns, how much lactate ringer solution should be administered over the first 24 hours? Over the first 24 hours, how much amount of fluids has to be administered? Now you are going to tell me the answer. For over first 24 hours, what will be your answer? So now tell me, yes, many students have answered correctly. For burns, for pediatric population, it is what? 3 ml of ringer lactate into your body weight of the child is 20 kg into your total body surface, that is 25%. That is equal to your 1500 ml. That is 1500 ml. So now tell me, how will you split this particular fluid and give in the 24 hours? Now answer me, how did you split this and give in the 24 hours? So you're going to split this 1500 divided by 2, that is 750 ml, right? So first 8 hours, okay, first half of the fluid, the first 8 hours you're going to administer 750 ml, and For the rest 16 hours, you're going to administer the rest fluid, that is 750 ml. Right? Yes. So let's go to the next question. Yes. Very good. Shweta, Rajkumari, very good. So next question. A 28 years old female present with deep partial thickness burns over her left thigh. After accidental spillage of hot oil, so the wound is painful. The wound is painful with slough and no signs of infection. What is the best dressing option to promote? As they are telling, the wound is painful with sloughing and no signs of infection. They are talking about second degree deep partial thickness burns. Now tell me, what promotes the wound healing? Yes, very good Priya, very good Mona Lisa, very good Dibesh. Hydrocolloid dressing or collagen dressing we will be giving to such patients, right? Hydrocolloid dressing or your collagen dressing we were giving to these patients. So no dressing and exposed to the wound hair is done to the what dressing? It is first degree burns. Paraffin gauze dressing we are doing it for second degree superficial burns, right? Second degree superficial burns. So silver nitrate dressing, we are not using it. And now tell me, now put in the comment box what is the important limitation it causes. What is the important limitation silver nitrate dressing causes? जय श्री राम, कैसे हो? मैं बढ़िया, आप कैसे हो? ठीक है. Now tell me children, silver nitrate dressing I have thought about and limitation for a silver nitrate dressing. Now tell me what is the answer. Very good. See Priyanka Patra, if I have a chance to meet you, I will definitely give you a chocolate. Right? Black staining of the wound after administration of the drug. Very good. Even Priya, Priyanka, Dibesh, they are favorite children. Mona Lisa also. Arpita also. Right? If we get a chance, we will meet and we will definitely. You people are from which place? Priyanka, Mona Lisa, Arpita, Dibesh, you people are from which particular place? Not sure. West Bengal. Okay. Ramya, you are from? Arpita is also from West Bengal. Priya is from Maharashtra. Dibesh is from Kolkata. Good. Yes. Sanjay is from Rajasthan. Great. Yes. So let's go to the next question. So a nurse is caring for a patient with deep partial thickness and full thickness burns covering 45% of the total body surface. Which of the following medication route should be avoided during acute phase of burns management? Now tell me. Yes, now tell me the answer. Which of the following medication route should be avoided during the acute phase of burns management? I'm waiting for your answers. Muva is from Andhra Pradesh. Yeah, a South Indian. Ramya is from Tamil Nadu. Wow. I'm also from Tamil Nadu. I'm from Pondicherry specifically. Very good, very good, very good, very good. Yes, yes. See, children, IV is the most preferred route. As we all know, IV is the most preferred route. Okay, IV is the most preferred route. Oral, if it is applicable, we can go for oral route also. Intramuscular route and subcutaneous route are contraindicated for administration for your burns patient. Obviously, the patient will be going for profound hypotension. The patient will be going for profound hypotension. Then the patient will be having severe vasoconstriction. So once they are having vasoconstriction, muscular hypoperfusion will be there. Muscular hypoperfusion will be there. So obviously, whenever you are administering IM injection, it is going to be useless. And what will happen? There will be no proper drug absorption. No drug absorption or no effect. No drug absorption or utilization. And no effect. So remember, like subcutaneous and IM are not preferred routes for initial administration of any medications to the burns patient. So, very good, Arpita, Rajkumari, Urki Vlog, Sanjay, Shweta, Ramya, Muva, Divyeshwar. Very good, very good, very good. Okay, so obviously it is very important that what particular routes are contraindicated or which is not at all preferred, that is subcutaneous and your IM route. Right. And in the nutrition aspects, when the patient is going to be having so much, like more than 15% of total body surface area of pain, okay, greater than 15% of burns of your total body surface area calculation, in that case, if there is a limitation with gastrointestinal administration, once again, okay, sorry for the interruption. Yes. So if the patient is going to have more than 15% of total body surface area of pain, area of burns, so in that cases, when the patient is progressing for paralytic ileus and those conditions, we can start with NG tube insertion. Okay, that is also one of the important point you have to remember in burns management. Okay. So in order to prevent the patient from going to paralytic ileus and those symptoms, we have to promote with NG tube insertion. Right? So let's go to the next question. A 35 years old male weighing 70 kg present to an emergency department with flame burns over 40% of his total body surface area. So according to Parkland formula, which is the correct volume of lactate ringer solution to be administered in first 8 hours? Now come on, answer me like a rapid fire person. Just come on, come on, come on. You have to answer me. I'm waiting for your answers. Very good. So many people have answered correctly. So now let's go to the calculation. It is 2 ml into weight of the patient into your total body surface area, right? So 2 into, what is the weight of the patient? It is 70 into your 40 percentage of burns. Now tell me, what is the answer? 2 into 70 into 40. Yes, now tell me, what is the answer? 2 into 70 into 40, that is 5,600. That is 5,600. So for first 8 hours, the first volume of the fluid you will be administering. So what you have to do? 5,600 divided by 2, that is equal to 2,800. So first 8 hours you will be administering 2,800. For second 16 hours, the rest of the fluid 2,800 ml you will be administering to the patient. Am I right? Yes. For the first 8 hours, 2,800 ml is the correct answer. Now do the workup for the, yes, very good Monala sir. Now do the workup for the old Parkland formula. Now do the workup for the old Parkland formula. So that is 4 ml into your weight of the patient into your total body surface area. So 4 into, what is the kg of the patient? 70 into 40. That is equal to, do with the previous formula. Work up fast. I want your answers fast. So now tell me, 4 into 70 into 40, that is your 11,200. 11,200 with the help of old formula. So now I want to calculate for the first 8 hours. First 8 hours and the next 16 hours. So what I have to do? I have to divide this 11,200 divided by 2. So 11,200 divided by 2 is 5,600 ml. So if we are using the old formula, 5,600 ml is the correct answer. But we are always going with the updated formula. Updation is always best. So the correct answer will be 2,800 ml only. Do not confuse yourself. The correct answer will be 2,800 ml only. Right? Yes. Yes, children. Very good. Good evening, Rapa. Why you were not in the initial phase? Yes, very good, Mona Lisa, very good. So here again, the last and most important high yield table I would like to project for you people is this, right? So what are these systematic functions or systematic changes you can see in burns patient, right? For cardiovascular, what are all the findings? Decreased cardiac output because of decreased circulatory blood volume. Burns shock, which means hypovolemia plus increased capillary permeability. This increased capillary permeability is causing what? Vascular leak, thereby third spacing edema is caused. Why this increased vascular capillary permeability is happening? Because of the damage, because of the burns, right? In respiratory system, airway edema, bronchospasm, inhalation injury, ARDS, followed by decreased PaO2 and your SaO2 level. In renal, obviously because of reduced circulatory volume, your GFR is going to reduce, and because of poor perfusion to the vital organs, patient will go for acute kidney injury. And myoglobinuria will be there, and especially in electrical burns, myoglobinuria will be there, and patient will be also going for oliguria. So in gastrointestinal, paralytic ileus. In order to prevent the paralytic ileus only, for prevention of paralytic ileus only, what we are doing? We are doing NG tube insertion, nasogastric tube insertion. Okay, no problem, dear, no problem. So curling ulcers. Curling ulcer is an important classical finding, and many times it is asked in MCQ also. burn-specific ulcer, and increased risk of translocation of the gut bacteria because of impaired digestion. So in immune response, patient will be going for extensive immunosuppression. That's why they are going for what? They are going for septic shock. Excessive proliferation of the microorganism will be there because of prominent immunosuppression. So that's why the patient is going for septic shock. As you all know, the patient is having increased susceptibility to sepsis, and the most common overall cause of death in burns patient is because of what? Septic shock. It is because of what? It is because of septic shock, right? Yes. So hematological, so initial heme concentration will be there, the hematocrit level will be increased, and then the patient will be going for anemia. At last the patient will be going for DIC. What is meant by DIC? DIC is your disseminated intravascular coagulopathy. So what is meant by your DIC? Anybody in the comment box, can you tell me what is meant by DIC? DIC is very good. DIC is your disseminated intravascular coagulopathy, which is a paradoxical condition where both bleeding and clotting will be there. So because of more amount of internal bleeding, the clotting factors will be produced in more amount. At last what will happen? The clotting factor depletion will be there and the bleeding will be so much profuse. This is very, very important condition. The important causative factor for DIC risk is your burns and even snake poisoning, and we have n number of causes for DIC. It is a very important condition that you also have to review before going for examination. Yes, very good. So thermoregulation, what about your thermoregulation? As we discussed in the primary slide, patient will go for hypothermia because of the impaired maintenance of your thermoregulation, right? So hypothermia due to skin loss and evaporative heat loss. So acid-base balance, again, the most important thing you people have to note is about the acid-base imbalance which is happening in burns patient. The acid-base imbalance happens. First is you have to think about metabolic acidosis because of lactic acidosis from hypoperfusion. Okay? Because of hypoperfusion, the patient, very good. Russell Viper will cause DIC. Very good, very good, very good, very good, very good. Yes. So now coming back to the metabolic acidosis, patient will be going for hypoperfusion state because of increased capillary permeability. So when they're going for hypoperfusion state, the patient will go for lactic acidosis. Lactic acidosis will in turn going to cause metabolic acidosis to the patient. On the other hand, in earlier phase, in the initial phase, the patient will go for respiratory alkalosis because of hyperventilation and craving for oxygen. Yes. In later case, when the patient is going for ARDS or inhalation injury, at that time the patient go for respiratory acidosis. So except your metabolic alkalosis, you can find all the important ABG findings here in case of your burns. The thing is, you should be very critically analyzing these things. Metabolic acidosis is happening because of hypoperfusion, and on the other hand, in the early phase, because of hyperventilation, the patient is going for respiratory alkalosis. Later, if the patient is going for severe form of ARDS and inhalation injury, in that case, the patient is going for respiratory acidosis. So you have to remember the patient will go for respiratory alkalosis, respiratory acidosis, as well as metabolic acidosis. So you have to remember, based upon the scenario or based upon the situation which is given in the MCQ, you have to take the correct answer when it is relating to the ABG. Am I right? So let's have a quick review. In case of cardiovascular system, the cardiac output is going to be reduced and the patient will go for burn shock, hypovolemia, and because of increased capillary permeability, all the fluid are leaking into the interstitial space, which is leading to hypovolemia and burn shock. In respiratory findings, the patient will be having respiratory acidosis and alkalosis. In early phase, he will be having hyperventilation and going for respiratory acidosis. In late phase, when the patient is affected with ARDS symptoms and inhalation airway injury, then he will go for respiratory alkalosis. On the other hand, bronchospasm, inhalation injury and ARDS is going to cause the following ABG findings. In renal case, GFR is going to be reduced because of the reduced circulatory blood volume, and the patient will be going for acute kidney injury because of impaired circulation to the vital organs, including your kidney, and myoglobinuria will be present especially in case of your electrical burns. So especially in electrical burns, there is an ABG finding. Anyone can comment me what is the specific findings in case of your electrical burns. And in immune system, immune suppression will be there. That is the reason the overall cause of death for patient on burns is septic shock. Hematological, heme concentration will be there. The hematocrit rate will be raised, and the patient will be also going for the risk of disseminated intravascular coagulopathy. Thermoregulation, patient is going for hypothermia. Acid-base imbalance we have discussed earlier, right? Yes. So that's how we have came to the end of the session of burns. I hope you have got all the updates regarding burns, right? So please put your comments, your feedback in the comment box so that I can able to connect with you more frequently. And this is my particular page. You can follow and ask your queries whichever it is needed for you, and I request you to show some support on this page as well. So whenever you have any doubts, you can immediately contact me through that page. And for Plan C subscribers, we are very active in the group. Whenever you have any scientific query, you can connect with us. If you are a person who is preparing for NORCET and who expect NNL to have lectures in English, this Plan C plus English edition is one of the most important plan. And the most important thing you have to remember is, like for Plan C subscribers, English subscribers, like for Plan C subscribers in English edition exclusively, we are coming with a fast track series where all the important concepts will be taught, exclusively in English, and we have a separate fast track edition which is going to be exclusive for Plan C plus English audience. So it will be a very, very happy learning journey for you, and all the videos will be start to get released on August for Plan C English subscribers. So every video is going to be exclusively in English, so you can learn to the greater extent and you can have a better preparation as well. So very, very, very happy learning, my dear children. Thanks for watching. Bye bye.